The reason I thought after all that heavy math, we can have a light after lunch session on death. Something's going to happen to all of us. But I think it's very important. It's very important. And let me start from a very human angle. So what really happens in ICUs is there's a lot of tension when a family member is dying. This becomes very emotional. There's anger. Doctors have been killed, and I'm not talking just about India, but across the world, doctors have been killed by patients' relatives because of what they perceive as wrongful death. There were at least 3 instances that I know in the US where the son or a close relative has gone in and shot the doctor because he felt that not enough was done. On the other hand, you'll see movies in India where they kind of portray doctors and hospitals as unnecessarily prolonging death with machines in order to make some money. So it's a kind of damned if you do and damned if you don't, because you're simultaneously accused of doing too much or doing too little. And I thought it might be a good idea to learn some of the basics of what really happens over the dying process in the ICU and where machine learning can help, because if we do have enough data and if we all understand this a bit better, then we can probably reduce mortality in patients and doctors as well to kind of prevent some of the unseemly things that do happen. And you may seem to think that this is a bit of an exaggeration, but the problem is one of not just the emotion of the close one dying, but is overladen with guilt that maybe they were not there when the person was dying. There is a kind of conflict within the family between siblings as the one person is kind of close here and possibly looking after the parents, and the other person is away abroad. And so all of this comes into play. And on top of that, in corporate hospitals, there are issues with billing, which people deliberately misunderstand. And so there's a whole lot going on here surrounding death, which is not necessarily medical. But today I want to discuss with you what really happens, so as to open some of your eyes to what doctors can know, don't know about death. And why this is important is because over the last 10 or 15 years, there's been a profusion of different kinds of therapies, invasive, highly invasive therapies that can actually truthfully prolong death or even cure death temporarily while we stabilize patients in order that organs can come back online and look for reversible causes. And we'll discuss a few of them today. Now, a lot of this is done as the art of medicine. There is not a lot of data, but there is a lot of kind of experience that comes with knowing patients and knowing how they behave. But it's still far from a true science, because a lot of it really is down to personal experience and pattern. I think Dr. Suresh talked about pattern recognition by experts. I think that's very, very important even at this side. And I know you're already doing it, but I want to encourage all of you to interrupt me at any point if something is not clear or ask any questions. So the first question is really, what is death in an ICU? And I think if you even look at it from a cell point of view or an organism point of view, you want to define what is life in order to get to what is death. So it's far from just a philosophical question, because death really is not life. And life is a living, functioning organism that is able to metabolize energy from the outside for its own purposes, can reproduce, can pass on information, both genetic and non-verbal and non-genetic as well, and a conscious being who's engaging with the senses around the world. So if none of this is happening, if all of this is stopped, then you can kind of think that that is death. I want to give you a visual representation. So the next 5 images you're going to see of patients, 2 videos and 3 still images, are all of my patients who have clinically who have been dead, in the sense that their heart has stopped, their lungs have stopped, they've lost consciousness, they've had no rhythm, and they had a period of external cardiac massage and defibrillation, which is applying shock to the heart in order to kick it back into a normal rhythm for at least anywhere from 20 minutes to 90 minutes before the ECMO was fully established. I'll talk to you a little bit in ECMO. So this is a patient 24 hours after having had a massive heart attack. So he crashed in the cath lab, he's been massaged, and he's been fitted onto this machine. You can see in the lower corner, the number 2.03 or 2.1. That's the number of liters that is flowing around in this patient at the moment. It's far from the 4 to 5 liters, but this is more than enough to keep the patient's organs well alive. And you can see that he's actually engaging in chest physiotherapy at the bedside, fully conscious. So he had an arrest of about 20 to 30 minutes. So this is a lady who was an elderly lady who was awaiting lung transplantation. She had a condition called idiopathic pulmonary fibrosis, which is nothing but a scarring of the lung tissue, which is the interface between the air outside and the blood in the lungs, very, very important interface. It is the only interface where carbon dioxide can go out and oxygen can come in. So when there is scarring, and over on top of that, she developed an infection. She had a crash because the carbon dioxide level went up very, very high and an oxygen level went down, and her heart stopped as well. In this case, we've used a pump, but mainly you can kind of see the pipes at the back. There's a black pipe or blackish pipe, which is taking deoxygenated blood to the oxygenator or the artificial lung, and the bright red blood, which is oxygenated, it's coming back towards her. And you can see in this video that she's reading a letter from a granddaughter about 2 or 3 days after cardiac arrest. So again, an episode of death from which she was revived. Let me just go. Okay, so these are 3 patients. So patient on the left had a viral infection of the heart. It's called a myocarditis. He crashed, and again, he is being supported. He's still being supported by the machine. The heart is working, but it's not having to actually do any work. The work is being done by the pump, the centrifugal pump, and he is being mobilized in his bed. The person in the middle arrested from COVID because his lungs were not working. And when your lungs don't work and the oxygen level in the lung begins to fall, at a particular point, the right side of the heart begins to struggle. Everywhere else in your body, when the oxygen level falls, your blood vessels vasodilate or they become soft. But in the lungs alone, they vasoconstrict and become hard. It's an evolutionary aspect of lung because it wants to drive the blood away from an area where there's low oxygen to an area in the lung where there's high oxygen. Unfortunately, when this happens and oxygen falls all over the lung, there is not enough oxygen. The vessels harden and the right side of the heart or the right ventricle begins to struggle. And that usually, especially in patients who were normal before, and we've seen a lot of this in COVID and ARDS, they suddenly arrest. And that's because the right ventricle can't work. This person was revived. He spent a long time in ICU, and he gets an illness called critical illness myopathy, where the muscles and nerves don't work. So here he is being assisted up to find his footing and to get a little bit of assisted weight support. So they have the sensation of being alive. So there's a lot to being alive. There's a sensation of movement, sensation of feeling your own weight on the planet Earth. All of this feeds into the patient's psychological well-being. The third one is a person who had a poisoning, and he had a cardiac arrest from a suicide attempt. But however, he has recovered enough to do physiotherapy. So these are the different kinds of patients that we see in an ICU who have died or been revived from the dying, or the end stage or the post-end stage of dying, which is cardiac and respiratory arrest, and brought back towards normality. So this is what I meant by extending the idea of what is death, because about 20 years ago, these patients would not have survived. Why is this important in an ICU? The first and foremost is not for the patient himself, but for other people who are suffering. On the left corner, the first image is one of a normal brain scan. You can see quite clearly that it's you can distinguish between the gray matter and the white matter. The rest are patients who've had a bleed into their brain, and you can see that that kind of texture difference goes away, and also the ventricles or the kind of spaces inside the brain which need to be at a particular pressure in order for cerebral circulation to happen, that begins to fill up with fluid, and soon the reflexes of the body begins to stop, and these patients are classed as brain dead. They can be assisted with the ventilator. There is a clear criteria for who is brain dead and who's not. And the heart continues to beat for a while. It could be a few hours to a few days. And we use that window period to take organs for transplantation. Previously, we used livers, kidneys, heart, lungs is now expanded to intestines, pancreas, hands, and even face. These are some of the organs or parts of the body that can be useful for other people who are suffering from end-stage disease. But more importantly, it's for the patient's own benefit that we understand the process of dying, who is going to die, who's going to survive, who is going to kind of get out of ICU, but with a lot of disability. And the reason for this is this German study, which came out about 2 or 3 years ago, where it looked at patients and how arbitrary the decisions were regarding very life-saving. And they found, and this is a very regular hospital. It wasn't a university teaching hospital. So here people were making decisions. And the essence of that study was that it was trying to say that they were very inconsistent decisions, because all this was what I call the art of medicine. It was not based on true number crunching or truly knowing what's going to happen. Even if you had these risk scores, it's very difficult to predict, even in the low risk scores, who's going to actually die, and among the high risk patients who have expected high mortality, who is going to survive. And we'll talk a little bit about where machine learning comes into it. But here, the essence of this study was that they were not intervening and they were not giving life-saving treatment. They were not initiating it, or even if they initiated it, they withdrew it. And especially if it was invasive, and especially if the patients were elderly. So you can see that there is a cohort where they come in where there is, I wouldn't really call this a prejudice, but a clinical prejudice is already there, saying that these patients probably won't survive. So let's not waste resources there. The problem is, while this makes sense in the setting of a hospital or a socialized or nationalized medical scheme, as far as the individual is concerned, it is disastrous. So this is what the problem of risk scores is. They do not really accurately predict for the particular individual. And that's going to be the thing of my talk. So just before we go, a little bit about the biological philosophy of the hierarchy of death. On the right-hand column, I've listed all of the ways in which individual cells die. I think today, the person that I heard, not the first person who spoke, but the person from Georgia Tech was talking about the causal estimation or causal estimand. Essentially, what my understanding of it was, he was trying to work out whether there was some kind of a mathematical relationship so that he could predict in a single cell what is going to happen to it if you knocked out a particular gene. Imagine, all we want is to know what happens to the entire one single individual, and even that has really great difficulty. But what I took away from the talk was that this is really the holy grail of science, is to be able to predict with accuracy. Now, there are a variety of different kinds of cells dying. In fact, all of us, some of the cells in our body are dying right now with a condition called apoptosis. This is programmed cell death. It's a way in which the organs replenish cells. Specifically, it happens all over the body, but it happens quite a lot in your intestine. Necrosis is where there is an insult to the cell and the insulting pathogen is sent out a signal, and they are damaged by the immune system. And there's a combination of this. So if individual cells are dying and the bulk of the organ is still intact, it can survive, because there will be replenishment, or there's enough physiological reserve in all of the organs in our body. Even in the brain, there's enough plasticity for it to survive. However, if a significant amount of quantum, and it's very, very difficult to know what this quantum is, when it's acute, it's a different kind of a value, as opposed to somebody who has a acute situation overlaid on a chronic situation, then the patient has adapted and other adaptive mechanisms have come in. However, an organ can fail, and then as in the case of sepsis, any catastrophe in the ICU, multiple organs can fail. And we're more familiar with the death of the whole person itself, either from brain death, which we just saw, or cardiac death. And entire species can go extinct, which is also a biological death, because that species is never going to come back. An entire ecosystem can be destroyed, and an entire planet can be devoid of life. It might have harbored life. So these are the different hierarchies of considering death in biological. And the reason why I put this up is that there are connections between all of it. Individual cells behave like individuals in a society, or part of a greater biosphere or an ecosystem. There is continual feedback between the cells and the rest of the body, between other cells, between the microcirculatory system surrounding it, so that it's like a huge network of signaling going back and forth. And that's where the problem lies, because very difficult knowing just individual numbers. How do you compute the whole network? So just to say that the cell could die, its components could be torn apart, or it could be completely intact, but it cannot do its work. We look at an example of that. Or the milieu, ecosystem in which it is embedded, which is the microcirculation, very, very important. One of the most important things that fails catastrophically in patients who suddenly die is actually the microcirculation. The macrocirculation goes, but most of the problems are coming because the microcirculation is failed in a profound manner. I want to give you a little bit of a visual. You can look at the rounded blue dots. I don't know if I can point on that. So you can see that a very nice, curvy, beautiful, well-structured hepatocyte. And out here, you can see that this is imbibed a lot of fluid as in the process of actually dying. All of it happening in the same ecosystem. So this is cellular death. Don't worry too much about this slide. I just put it up there to say that whenever there is an interaction with any kind of insult, a toxin or a bacteria or a virus, or sometimes even if nothing in autoimmune diseases, there is a signal going out from the cell to the immune system saying, come here, help me, repair me, or eat me up, or don't come here. And sometimes mixed signals keep going. But the end result, what happens is either the tissue gets repaired or it gets eaten up, or far worse, it sets up this chronic inflammatory process, continually keep giving a signal even though the original insult is gone. And this is very, very important in the condition that we are particularly studying, which is systemic inflammatory response syndrome. Right. So here is an example of, this is a patient who most of the patients who have this kind of this is a blood gas, by the way. So it looks at the pH on the top. Let me just get that a little bit closer. So the pH, the normal blood, most of you might know. The reason I'm making it very basic is I think the audience is divided between very heavy on the math and very heavy on the biology. So some of you who are not familiar with this, so forgive me if it's a repetition of basic stuff. The pH is normally between 7.35 and 7.45. So not like in chemistry where 7 is the dividing number, but it's 7.35 to 7.45. Anything below 7.3 is considered acidosis. And the reason why it's quite narrow is most of the enzymes in the body function best at this particular pH. If you're sitting here at sea level breathing air from the atmosphere, which is 21%, you will have a partial pressure of oxygen of about 120, 150 if it's completely devoid of water vapor. That's the maximum you'll have. And your oxygen saturation will be anywhere from 95, and that's the number there. So you can see that, that's 99%. And because this is, we are actually infusing oxygen into the blood, it's really quite high. So this is a maximally oxygenated patient. However, the patient has, and the normal level of lactic acid in your body should be somewhere around 2 millimoles, at the most 4 millimoles. Here it's 15 millimoles. This means that the cell may be structurally intact, but it's functionally zero. It's just not accepting or able to use oxygen to metabolize, to get its energy, to form ATP. It's switched on to anaerobic metabolism. And anaerobic metabolism, the byproduct is lactic acid, and that's the reason why the pH is falling. So here is a structurally intact body, but functionally it's completely gone. This is a very bad prognostic sign in the ICU. Death is usually imminent when this happens. This is another very important. On the left of your slide is a normal microcirculation. So you can clearly see how the cells are embedded in a very beautiful, well-flushed, cleanly delineated microcirculation, arterioles, capillaries, and so on. And this is somebody who's really critically ill. And here you can see that there is benefit. So multiple things happen in the microcirculation. Parts of the microcirculation don't have any blood going into it. Other parts have too much blood going into it. But most important of all is these blood capillaries, which are usually only 1 cell thick, start leaking fluid. The moment they start leaking fluid outside, the pressure here gets very high. And if the pressure and the gradient between the arteriole and the venule is not maintained, this external pressure actually causes a lot of problems. So one of the things that we do when these patients arrest, I'll show you one or two pictures, they bloat up quite quickly. And so we get them on a dialysis machine and start taking out quite a lot of fluid. The most we have taken out in patients who are like this over a period of something like 15 days is close to 50 liters of fluid has come out. So it's that leaky, these capillaries. Right. Now, what is happening at the macroscopic level? So this is from actual patients. So we do this as part of the training program because we have a team that has to resuscitate patients, make a decision about whether they're going to fit them onto the artificial heart and lung machine. This is a person who's kind of arrested. Even these little bumps are just artifacts coming because of the pressing down. So the oxygen levels are very low. This patient is crashed. This is only coming from the external cardiac massage. And you can kind of see that. Two things are happening here. This is because the patient is actually being pressed upon the chest, is generating a systolic. So the normal systolic blood pressure is 120 by 80, 110 by 70. But the important thing I want you to notice here is the very low diastolic pressure. So this is a condition where the tone in the blood vessels has gone out completely. There is no pressure head in the system. So it doesn't matter how much of a systolic pressure you're generating. If your mean pressure is coming down and your diastolic pressure is very low, you know you have an immense microcirculatory failure, and the tissues are going to be awash in fluid, and they're not really going to get any nutrients or oxygen. This was the blood pressure of the patient recorded just before the arrest. So this is the kind of thing that we usually measure in the bedside. So even if you manage to ventilate this patient, usually lungs are quite stiff, but you're able to get a little bit of saturation, you find that there's a profound vasoplegic state. Vasoplegia, vaso is no tone, plegia is no tone, and vaso is the vasculature. Basically paralysis of the vasculature. You need a pressure head. And this also happens classically in septic shock and post-arrest. So here in this resuscitation, we've been able to get back a rhythm that's fairly good, but that's not really doing much good because the patient's blood pressure is really, really low. And this is the patient's own blood pressure, but it's very low, and also the saturations are very low. So it's a combined heart and lung failure in this patient. And if you don't do something quickly, this is going to slide back and this patient's never going to get better. Right. So this is what happens. The blood doesn't flow, not enough oxygen goes to the tissues. They switch on to anaerobic pathways or making ATP. So if you kind of used oxygen to make your ATP, you'll make around 32, 34 ATPs for every molecule of glucose that you break down. But if you use anaerobic pathways, you'll make about 4 or 6 ATPs, not enough to do even the most basic. If you're an yeast and you're fermenting alcohol, that's all right, but not if you're a fully functioning human being. So very quickly, lactic acid builds up. The carbon dioxide doesn't go because the patient's not breathing. That adds to the acidosis. And once the pH begins to fall, all of the cells begin to start dying. So this is what really happens in real life. The reason why I know you've seen, I want you to get a flavor for critical care so that when you think about your data and you think about the numbers that are collected, it'll make more sense to you. If a patient is arrested, someone is with the ongoing CPR, and the rest of the team is trying to access the major blood vessels. In the adults, we usually go onto the groin. There's a big vein here which goes straight to the heart. So we put in a large cannula, we suck the blood out of the heart, we put it through a centrifugal pump and the oxygenator, and then it goes onto the arterial side. So one surgeon and one anesthetist here is trying to get onto the artery on this side. He's trying to get onto the vein on the other side. Using the ultrasound machine, throw back to the last thing. Very, very important to us to know that we've located it. The blood will look black, whether it's in the arterial or the venous side. Everything will look black. It'll look thick. You won't know the cannulas. There'll be no pulsations because the heart has stopped. Very difficult to know what's happening. So you need to be a little bit expert. So we kind of use a combination of things, but if you get some kind of pulsatility, thanks to the advances in ultrasound, we now know that we are in the right, that you're not taking blood from the artery and giving it into the artery, or not just taking it from the vein and giving it back to the vein, which is less dangerous. So this is really one of the newer things since H1N1 in 2009, much more widespread. But after COVID, it's really seen a resurgence. It's a centrifugal, a very simple pump. So the blood comes from the patient. It's pumped into a gas exchanger. This is a PTFE membrane, and this membrane is a hollow fiber membrane which exchanges oxygen. And carbon dioxide is just controlled by how much of air you move in. There's an actual formula to it, which we work on. And there's also a formula from how much of oxygen is in the patient and how much carbon dioxide is building up for us to kind of, we have to tweak this a little bit to get it right. If you correct the carbon dioxide very, very quickly, that's a big problem because it can cause a very severe cerebral vasoconstriction. So you got to, it's a little bit of, you have to manipulate it right after the arrest. So many things are going wrong. But this is, this can now be taken to the bedside. And we've done this in a variety of small hospitals across Tamil Nadu, across India, in fact, in COVID, in a village in MP, and also in the Middle East. So it's very, very portable. Now, why do we do this? The idea is very simple. A patient has come and he's arrested and you don't really know the diagnosis. You don't know whether the original condition was reversible or irreversible. A lot of time it's just a heart attack. And you can take them to the cath lab and you can open it up with a PCI, or you may have to replace a valve, or you have to do a coronary artery bypass, or whatever you want to do. You don't have the time for it. And you also, even if you manage to get them back with a little bit of medicines which squeeze their blood vessels, that is actually very bad in the long term or even in the short term because they crash the moment you open up the vessels. And the reason for this is something called reperfusion injury. We can discuss that later if you want to. So therefore, by supporting these patients, we make sure that the other organs, the organ which is not at fault, for example, it's a heart attack, we're preserving the lungs, liver, and kidney. We are optimizing the patient, and then we can take our time. Same way for transferring a patient. A very unstable patient can be transferred over enormous distances. The longest one we have done is from Delhi and from the Middle East to our hospital in Chennai. So it can be done quite safely. It can even be done by road if the patients can't afford air ambulance. So this is a newborn baby. So this is about 2 days old. And here, because of a particular condition, there's a lot of aspiration of the stomach contents into the lungs, and the baby got secondarily infected to the important to the other antibiotic resistance talk that we had today. So there was Acinetobacter, which is multi-drug resistant. So went into septic shock. And here we can't access the babies, are too small for the groin. So we have accessed the neck vessels. So we take the blood out of one of the neck veins and then give it back into the artery in the neck. And I just want to tell you all, these are happy stories. The baby is thriving and doing extremely well. This is really a marvel of technology. And we're constantly learning even now. So there's a lot of these machines are also, it's a mathematician's dream or a modeler's dream, because they throw up a whole lot of numbers, which similar to what Dr. Suresh was saying, we don't really use all the data that we actually have. We don't even know it's there some of the time. So what do we do? So somebody was arrested. We talked about acidosis and building up lactate. So the machine kind of stabilizes all that. So this is about 4 or 5 hours after stabilizing, and you get a very low lactate. And preserved all of the internal composition of the blood and the microenvironment of the cells so that they don't start dying, which is the object of it anyway. So here, I told you the normal carbon dioxide level is about 35 to 45, so it's 172. And when lungs are not working, what happens is that the carbon dioxide can't go out. Concomitantly with the kidneys, the carbon dioxide can only go out 2 ways. Either it can go out through the air when you breathe out, or it can become bicarbonate and be excreted in the urine. So if you have renal failure and your lungs are also failing, all of this carbon dioxide will just form bicarbonate, which will form hydrogen ions, which will make you very acidotic. Okay. So why do we do this? And it's because we do believe that in a significant portion of people who come arrested without any previous history, there is usually an underlying cause that can be treated. So in this patient had a viral infection of the heart called myocarditis. I think you can appreciate the echo that the heart's not really contracting. But after having spent a few days and you just rested the heart, say you don't need to do the work, the machine will do it for you. About 5 days to 7 days, most patients recover completely and can be taken off. So this is a case of viral myocarditis that recovered completely. Even if it doesn't recover, the stability gives you one organ failure as opposed to multiple organ failure. And we'll come when we talk about the risk scores in a minute. So this is somebody whose left ventricle had a heart attack. The whole ventricle got scarred. Nothing more could be done. So we take the blood from the left ventricle and we put it onto the aorta. It's called a implantable left ventricular assist device. You can't do this in an emergency in a hurry. The outcomes are poor. So we stabilize, make sure all the other organs are functioning, and then we can do it. So either you can bridge them to recovery or you can bridge them to some more definitive this thing. So I'm coming on to the main topic that we have. So what is systemic inflammatory response syndrome, and what does sepsis exactly mean when you talk about that? So this is really at the base of it is that it is a inappropriate immune response. By that I mean it's either too much, what's called a pro-inflammatory profile, or it's too little, or it's actually going against fighting the bacteria or virus or whatever the insult is, and it's called an anti-inflammatory profile. Or sometimes when it should be getting out pro-inflammatory cytokines, it's actually doing the opposite, what's called immunological dissonance. So it's really an inappropriate response to what is actually happening. Too much, too little, or inappropriate. It can happen in anything, pretty much any catastrophic situation, infection, surgery, difficult births, trauma, burns, putting them on ECMO, arresting. We saw one example. When they arrest, immediately the body's responses, something horrible is happening, and the immune system just lets the whole army out. The unfortunate thing about the army is there's a lot of collateral damage with the immune army. They don't really care at the point when they go berserk about attacking bugs, or even if there are bugs or there are no bugs or no bacteria, they start killing cells right, left, and center. Not only do they do that, they induce cells to them commit suicide themselves as well. So this is really what happens. I'm not exaggerating it. So there's a profound, and if you have an infective basis, this is from an Indian ICU, more than 1/3 of these patients will die. Now, this is a person who had a retained tampon, and I just wanted to put this picture up to say we talked about staphylococcus infections today, and you can see the microcirculatory failure is quite significant in these patients. And this is called toxic shock syndrome because of staphylococcus. And again, these are all multi-organ dysfunction syndromes. And this is the same patient being supported by the heart, the lungs, the kidney, and the circulating system as well. So this is how an ICU would look for some of these sickest patients. Now, where can this help? If ever a particular problem in medicine was crying out for pattern recognition and data mining and machine learning and relearning and setting up templates to improve things, I think it is this. Because for one thing, in most of the chronic conditions, you may have some time to think and go back. In all of these acute situations, if you had an algorithm that ran fairly quickly, then I think it would be that more people don't have to spend long. Now, I have about 30 years experience as a doctor, out of which 25 years I've spent in cardiothoracic ICUs. So I have a flavor, but it shouldn't be like people should have to wait 25 years. I think if that experience can somehow be made into a model that can predict quite accurately, I think it's going to be fantastic. But there are problems, huge challenges. I'll come to that in a minute. So these are two papers quite recently. I'll give you links to them. So one was published in NEJM and the other was published in Nature Medicine. So the first one simply looked at patients coming into the hospital and looked to see, I mean, this is very simple. If you're older, you have diabetes, you have kidney failure, you're on immunosuppressants, your chance of surviving the infection was low. So it just looked at who was at risk using the usual variables and predicted and saw if the prediction was more accurate than current risk scores. And the other one was all the patients who were admitted, they looked at particular things, what is the blood pressure or BP or SATs, and looked at it much closer, more intensely through this targeted machine learning system. And they showed a mortality benefit of about 3 or 4% in this particular study. Now, I don't want you to read too much into it. These are patients who had infections and maybe the treatment protocols are a bit different. It's very difficult to know from the data that is given. However, only about 0.9% of these patients had septic shock. But irrespective of that, I think a 4% or 5% improvement in mortality is a fantastic thing. And this was using the most basic stuff that you record in an ICU, not even the number of things that I showed you. They weren't even measuring the carbon dioxide, I think, in this particular study. Now, what is the problem? I talked about challenges. The problem is, the first thing, when you try to look at the particular risk profile of a patient, you use a commonly used, there are many risk scores. We use Apache. Apache 2 is the one you use. And once they're admitted, the evolving trajectory in the ICU is by something called a sequential organ failure assessment, or SOFA score. And again, that is basically common sense. The more organs that start failing, the more your chances of dying. So this is all we have currently. So we're not even scratched the surface of what is possible. And what is it? Even the monitoring that we are currently doing, which is carbon dioxide, pH, oxygen, lactate, it's not being done in real time. It may be done sometimes every 1 hour if it's a fantastic ICU, or every 4 hours. And by that time, multiple things might have happened. And you've already set in motion. This is similar to why patients present so late. You may wonder, oh, my uncle, he was absolutely fine. Now they're saying he's got liver failure. That is because from when the original inciting problem, subclinical issues, all of that, where data is available, by the time it comes to clinical attention, it basically means that you're long past. In lungs, that certainly, by the time you get breathless, most of your lung is actually gone. You can have about 20% of your lung functioning and still not feel breathless if you're not doing very many things. So the point is that we're not collecting enough data. I think the Guy's Hospital critical care consultant in ECMO, a person called Nick Barrett, he said every patient is a reservoir of data. So you really shouldn't be looking at studies and you should just collect all the data and all the patients. And I think there's some case to be made for that. We don't have all of the genomic, there's about the pro-inflammatory profiles, what genes are turned on, what are turned off. We don't have, even that can be done, but we won't have access to it at the bedside. Same with proteomics. And last but not the least is the microbiomic. And this is very, very important. A significant part of the cells in your body are actually microbes. And the microbes in your gut interact with the immune system in as yet unknown ways. And one of the commonest causes for sepsis is when the barrier of the intestine breaks down, and even when you put a patient, when we do surgery and you put them on bypass, you put an ECMO, this barrier just melts away and there is an invasion of bacteria. And there is an even more interesting phenomena called the gut-brain hypothesis for sepsis, where through the autonomic nervous system, there is signaling going on between the gut and the brain, and the brain is actually giving information as to whether you have to commit apoptosis and just kind of give up the ghost, or you should start fighting. And it's interesting. It's a hypothesis not fully tested out, but there is a lot to be said for gut bugs, because most of the time, the sepsis is caused by gut bugs in ICUs. And again, we just talked about immuno. We really don't know what is the status of the immune system. We do a few cytokines here and there. You do some interleukins, you do some interferon, alpha necrosis factor. You have an idea that something is going on. You're not very sure whether it's good or bad. And last is something that as a personal interest for some of us is the redox status of the patient. Is the patient getting too oxidized? Is the reduction compensation not adequate enough? We don't know anything at all about this. And lastly, even if we do know it, it's all in patches, and we really don't know how this interacts. Now, in my limited view of artificial intelligence and machine learning, I don't think any human being is going to be capable, even given all this data, of putting it all together. It has to be machine learning. It has to be artificial intelligence for it to eventually produce a profile of a patient coming into ICU. Are you going to die? Are you going to survive? And let me tell you, even if clinicians are not interested in it, insurance companies will be, because right now, ICUs are the most expensive places anywhere for healthcare, anywhere in the world. It doesn't really matter if this government is paying, the insurers are paying, or you're paying out of your pocket. So anybody who can have an idea, and this is actually a very practical problem. The first thing a lot of people are paying out of their pocket, last, doctor, is he going to survive? Is it worth spending all this money? And that's a very legitimate question. Okay, so, but we don't have the answer to that, which is why when I started the talk, I told you about patients and relatives getting angry. It is because they sense that the doctor himself is not very sure what's going to happen to the patient, but they take that to be that they're trying to shield the information from them. So if we can get at some point in the future, it'll be nice to say this particular model predicts that he's very likely not going to survive in that individual patient. That would be the holy grail for me as far as ICU is concerned. Just to say that even existing data, there was a French study done in 2014, which looked at anti and pro-inflammatory profiles in genomes of patients with sepsis. And Alanki was a real brain box with Narlikar from IIT, as well as Nandan Sinha, looked at the same data on my say-so. So we looked at bioenergetic failure genes that were switched on and off, and we found that it was far better at predicting outcomes in the very same data. So the reason I put this up, this was done about 6 years ago, is that even in existing data, there's a mine of information which we're not using. I think I have just another 10 minutes. So this brings me to our own interest in this. So we are trying to test out something called the oxalic-sulfuric oscillatory hypothesis in sepsis. So the idea comes from, this is an actual picture of a meromictic lake. So these lakes are extraordinarily silent, in the sense, no ripples, nothing. So they're very stagnant. So the top part is oxygen rich, and as the decaying matter and leaves and whatever animals that fall into it die, they sink to the bottom. So there's a gradient from high oxygen to high sulfur, and there is a transition zone, which in some of the lakes can vary seasonally, or it could be over years or even decades. But what that does is the transition zone, as it moves up and down, it signals what kind of life can flourish there. And these have been studied enormously. So it gives an idea, and it gave us an idea because we have a very similar, these are called chemokines, because there is a gradient of a particular chemical. So the oxygen level is going from high to low in the lake, and the sulfur level is going from low to high in the lake. And those are two parallel opposite chemokines. We have an exactly similar one. You have a high level of hydrogen peroxide in the lungs, and almost very low. And we're talking about orders of magnitude 10 power minus 6 to 10 power minus 12 of H2S, and it's reversed, more or less reversed in the colon. So we have a chemokine. I don't want to go into the details of that, but there is a hyper-reductive biochemistry of H2O2 and H2S. So the interactions, when there's an oxygen challenge, when there's oxidative stress, is very, very different. It's almost like the H2S and the H2O2 are oscillating with each other. And we are just trying to see whether this provides us, and why you may ask why we picked H2O2 and H2S, because these two molecules, we're also looking at NO, these are gasotransmitters, NO and H2S and H2O2. Because there are other oxygen-free radicals like superoxide and OH radical, but because they're ionized, they can't cross barriers. And because systemic inflammatory response syndrome is dramatic, fast, multi-organ, and evolves very, very quickly, the signaling has to be something that is all pervasive. It can go through membranes, it can be in the blood, and these are the candidates at the most elemental level that we can pick up, or molecular level that we can pick up, which are simple. Plus, they have a very deep connotation in biology. So there is one theory for the Permian mass extinction is that there was a movement of hydrogen sulfide very furiously out from down to into the oxic atmosphere, which caused about 95% of all life to perish. So there are kind of glimpses of interest. So as I said, Muralidharan in IIT, as well as Ashish Sen and Rahul and Gautam, we all kind of do this as a hobby. So it's taken us a long time. So this is our hypothesis, is the fundamental imbalance, or at least the fundamental signaling process to do with a difference between H2S and H2O2. And we're not very sure where NO comes into the picture. And why did we pick as a cardiac surgeon for this to do? One of the most potent ways in which hydrogen peroxide is produced in the body, or oxidative stress, even more than bacterial infections, is the heart-lung machine. So the moment you put the patient on a heart-lung machine, it goes up 150-fold. The amount of hydrogen peroxide. So we have a great model where we have a patient with an oxidative burst, and we can and also in sepsis, as the pathogen or the bacteria or virus interacts with the immune system, one of the key molecules, don't worry about the rest, is hydrogen peroxide, which is released, which basically means the blood is suddenly, or the microenvironment is suddenly going to a very oxidized state. And I just want you to, again, don't worry too much about the details. You can see here that H2S replenishes something called glutathione, and glutathione is the one that breaks this H2O2 back into water and makes it more safe. So there is an intrinsic balance between the two. So that's why we picked the molecules. Rahul wanted me to add a line about the challenges, and I think it's very important. The first challenge is, of course, the usual challenge, which is money. And even if we do get money, each department wants, a little bit more for himself. But we haven't had much of that problem because Ashish Sen has been a great guy. So what we have done so far, so when we decided it was all very exciting to come up with a hypothesis, we found that we couldn't actually measure anything. And the current methods of measuring this, taking the blood and going back to the lab and doing, the usual assays just wouldn't work because they were so short-lived. So we actually built the sensors. We made point of care devices for all of the three. And I won't bore you with all of this, but we published a lot about those probes and how they work in saline and normal people as well. I've had my own H2O and H2S levels done. So that's been done. We've done a few animal work. This is something in rabbits where we infused them, put them on bypass, looked at the H2O to H2S levels. But unfortunately, they tolerated bypass very poorly. So right now, Dr. Barnidharan and the team in veterinary have developed a single organ where we are studying the lungs and the liver in isolation. And we hope to look at macro function like compliance and gas exchange and bile production in the liver by varying the amount of hydrogen peroxide and hydrogen sulfide that the particular cells are washed with. And that's what we hope to do. Build on this. And if any of you are interested, we'd be very, very happy for you to join us. Thank you very much. Thank you.
Hi, nice talk. So I just wanted to know, since there's a connection between gut microbiome and cardiovascular diseases, so I just wanted to know, do you do some microbiome study on patients to understand their gut microbiome function?
We don't, not at a hospital, mainly because in most private hospitals, anything else that comes has to be added on to the patient. So if you want to do it as a research, we can. The problem in, the practical problem in most hospitals is that the patient burden is so high, the microbiology department can barely afford to do other things. But yes, we would love to study that. We've been talking a bit about it. We don't really have the analytical tools currently in our hospital to do it, but if samples can always be given. This, what I was talking about is the gut barrier failure in patients who go on bypass. So people have actually detected the gut bacteria translocating into the blood as soon as you go on bypass. Why this intestinal mucosa becomes leaky, no one actually knows. But yes, I think we should be studying more about these patients.
I think leaky also comes from the microbes. They play a role over there.
Yes.
So doing this kind of study would be very beneficial for the patients to understand if they need to make any dietary changes. And the other question I had is that we know that gut microbiome, they produce TMAO, which is trimethylamine and oxide from certain nutrients found in red meat, eggs, or animal products. So in that case, would you recommend taking non-veg? I mean,
I think I agree with you that certain foods are quite high in nitrosamines. But I think what we have seen, especially during COVID, when we had patients with, and this has been well documented, with high BMI dying much more from the same level of disease. And the reason, so we went into an extreme low-calorie diet for a lot of these patients, and the survival, we had about a 70-75% survival. So, and there is now data to support that all calories should be cut. So to answer your question, I would suggest not only they stop eating meat, they stop eating altogether, in the sense, at least get it down to, I think the current recommendation is around 600 calories for anybody who has a BMI of about 25, because the BMI of about 26, for every point of BMI that went up, the mortality rate went up by 4%. So there's a direct correlation. All of our patients in our ICU get a low-calorie diet. It's modified according to what is happening to the GI tract. If they start getting diarrhea or they start getting a fever, it's immediately modified. It's always given NG. We don't give parenteral nutrition. We rather stop if we think that the BMI is high. We have found that patients just with fluid supplements have done absolutely fine. Yes, I think red meats can be a problem, but proteins at a low level is sometimes more easily digestible because the quantity is less. In my particular cohort of patients who have heart and lung failure, we have a big problem. There is a two-pronged problem. The one is that they are so breathless, they're unable to eat any amount, so they get malnourished. But they're also on steroids, and they also don't have enough oxygen to metabolize what little goes in. So they may have kind of, even if they come in with high BMIs, we find that their muscle mass is very low. So it's quite a complex thing. We have to build up muscle mass. We have to reduce the BMI. We also have to make them fit for the transplants, because that's a very grueling process. And in the lung especially, we can put in new lungs. The gas exchange becomes fine, but the ventilatory aspect, unless you're able to draw enough air into your lungs, it's pointless having good lungs. And that aspect is to do with the muscle function of the diaphragm and the chest wall. And this is extremely low in patients who've been on long-term steroids. So we do recommend some kind of a, not so much higher calorie, but a more nutritious diet in those patients. And that's worked as well.
Thank you, Dr. Paul. So I'm Tavpritesh Sethi. I work at IIIT Delhi, build models for the ICU with the AIIMS New Delhi, and spoke about our models on the first day for sepsis and shock prediction. So my question is, what is the temporal resolution of data that you have on these ICU patients? Is it like every half an hour, or monitoring data every second?
The heart rate, intraarterial blood pressure, end-tidal carbon dioxide, they are all in real time. They're available all the time, but somebody has to watch it. We have collected the data. I don't know the storing capacity. When we did a study for a company called Denko, we kind of stored the data, but otherwise it's not stored once the patient goes out ICU. The blood gases, if the patient is critically ill, we do it every hour. When they're more stable, we do it every 3 or 4 hours. Volumetric carbon dioxide, we do once a day. We do it twice a day when we are weaning the patient off ECMO, because that's a very critical this thing. Oxy test, we do at least once a day at the time we are weaning.
So what's the challenge in actually storing these data? The reason I'm asking is the first step towards building these models is actually doing that. We started with, in 2016, started with the Safe ICU initiative, more than 2 million patient hours, now warehoused at AIIMS, and that's when we could start modeling. So what's your challenge in setting up such a system which would warehouse these data towards?
I'll be honest with you, the first challenge is that there hasn't been a habit of doing it. There is not a big incentive to do it. to the people. I think that's a very horrible thing, but that's the real reason. I think it's not like somebody set out to say we're not going to store the data, I wouldn't be bothered. But it's something we're doing more now, and hopefully we'll get more. As far as the ECMO is concerned, all the data is stored. And I think we're planning to do some risk prediction with Rahul after this is done. Sorry, which hospital did you say you were?
I work with AIIMS New Delhi.
I see.
So
Okay.
we'll be making some of the data publicly
Yes.
available, but that's a pediatric ICU.
Yeah, so I think in an academic institution, the kind of profile of the people looking after is a little bit different. This is really just a place where people work and, go. I think the whole philosophy of the hospitals is different. That may be a reason.
Yeah, would be
That may
happy
be
to
a reason.
connect and discuss more.
Yes, yes, sure.
Yeah, hi. Himanshu from IIT Madras. So nice talk. I just was very interested in the last part that you were talking about, hydrogen sulfide balance. So have you looked at metabolic models between healthy and the critically ill patients, and whether you could identify which part of the metabolome or the metabolic network was getting perturbed or gradually getting perturbed as the patient are either going downhill or were recovering? So have you?
The short answer is no. And the reason is because there are a lot of problems in actually deciding what is a normal level of H2S and H2O2. H2O2, there are some values, at least we know the units, micromoles. For H2S, it ranges from nanomoles to picomoles to millimoles in different literatures. What we have done 15 normal patients now, normal people, and we've got a reasonable range to predict that. So to answer your question, that's the first thing. We're also going to look at persulfidation products downstream. And I think the enzymologist in IIT Madras who's just joined is also planning to look at some of these rate limiting steps.
Okay. So you're already in discussions.
Yeah,
so
but we haven't done it as yet, but we're thinking about it.
Okay, great. Thanks.
Yeah. I really enjoyed it. When are we going to produce evidence that can guide other parts of the world for how to manage Indians in an ICU setting? It's very refreshing to talk. I don't mean it in any simplistic way. A cardiothoracic surgeon talking about obesity, muscle mass, nutritional importance, gut microbiome. I really enjoyed it. So I think we really need to think laterally, and you must have huge amount of data sets. I agree what you said about we can't just collect data for the purpose of research when your focus is clinical, acute clinical need. But it is also the prime spot for generating such research. And I think this audience is especially machine learning interest now is across the world. Do you see that happening in the near future?
No, I think it's a very important point. I've got to actually tell you the same thing that Dr. Suresh said. The problem is he exactly pointed out as an example of somebody who is there, who's looking at the data, who's doing very well, and then decides he's got a better job. In fact, in IIT right now, Ashish Sen's, the guy who's doing the best work, he's got a job in Mercedes and he's moving out. We don't have a lab culture of juniors who are given a career path to moving to postdoc and then on to assistant professorship, or even we don't have people who don't want to pursue maybe a PhD, but who are excellent lab assistants who kind of can learn a particular technique and repeat it really well. When I used to work in the photocatalytic lab, there were lab assistants who could make the thin films much better than any of the PhD students, but they're unable to retain them in institutions like IIT and I mean, I don't know about the others, but certainly in IIT I can speak for. And I think that is a big problem. We got to create this ecosystem where researchers are well-funded. They're not running for one job because PhD pays so poorly, and because they, I really love doing this, but there's no career in it. And so there's a whole lot of other problems also. They do get married and leave. And these are practical problems. But yes, I think I think a step in the right direction. At least we've said that there is a problem.
Thank-
Is that my time up?
Any other questions? So,
Can I just make
yeah, go
a
ahead.
quick plea? Thank you, Paul. And can I
Yes.
actually make a plea for our co-organizers and all the faculty who kindly gave all their time and efforts. If we can produce some sort of summary document and recommendations and priorities for research and direction out of this 2 weeks, that would be fantastic. And obviously, the organizers ourselves can't do it, but if all the faculty also can join, I'm sure we can quickly produce a document that may be very, very useful for funding bodies such as DBT, DST, and as well as the DBT Welcome Alliance.
Yes, that's been kind of on our mind. So we'll definitely be in touch with everyone. And yeah. Anything else? Okay, so let's thank Paul again and we'll break for tea.